Yeah, hello everyone.
Garima ji.
Hello, hello.
Purnima ma'am also is joined. Purnima ma'am.
I think Aparna has also joined, but she is on.
Purnima ma'am is here, sir.
Hi.
Yeah. Aparna ma'am is here.
Aparna ma'am is here.
Yes.
Yes,
Good
yes.
to see you, Aparna.
Hi, lovely to see you.
Good afternoon.
Very good
Afternoon, Purnima ma'am.
Hello, ma'am. Purnima, ma'am. Hello.
Hello, good afternoon.
Good afternoon, ma'am. Hello, hello.
Purnima ma'am also is joined. Yes. Yes.
I think Aparna
Yes.
has also joined, but she.
Aparna is.
Purnima ma'am is here, sir.
Hi.
Yeah.
Aparna is here, and I just want to say there's a lot of drilling happening in our building. So I will be muting in between just to ensure you guys don't have to enjoy the drilling yourself.
Hello, ma'am. Purnima, ma'am. Hello.
Hello, good afternoon, everyone.
So shall we start the program now? Dr. Hari Kumar, sir, can we start the program?
We have around 20.
Or we have to, wait for a minute or so. I think Amir Ali ji is supposed to join. He's still not there.
Yeah, good afternoon. I have
Hello,
also
sir.
joined.
Okay, great,
I'm
sir. Okay.
just rushing from one meeting to another. So please, please start. Please start.
Thank you so much, sir. Yes. Yes, Sakshi, are you going to start today? How is it?
Ma'am, it's me today, Bhagwati here.
Okay. Okay, okay. Hello, ma'am. How are you?
Hello, fine, thank you, thank you. Welcome to all the participants. Today I welcome you to this particular event. I welcome all our esteemed guests and resource persons for the training program on building resilience of health facilities. This is a 3-day online training program conducted under the aegis of Jammu and Kashmir State Disaster Management Authority, the National Institute of Disaster Management, and Geohazard Society. Today is the second day. Before I lead you through today's sessions, let us have a quick recap of the proceedings of day one. The event yesterday began with an opening remarks from Dr. Garima Agarwal, Senior Consultant, Resilient Infrastructure Division, NIDM, and Professor Chandan Ghosh, who heads the Resilient Infrastructure Division of NIDM. We received valuable insights from the NIDM team on the importance of resilient infrastructure, particularly in hospitals. This was followed by an address from Sri Amir Ali, Nodal Officer of the SEOC Jammu and Kashmir. Sir elaborated on the activities undertaken in Jammu and Kashmir presently for resilience of the health sector, and he also touched upon the need to enhance the capacity of the emergency medical response and mass casualty management. The learning sessions started with Dr. Hari Kumar of GHS making a small presentation on keeping hospitals functional during and after disastrous events. This set the context of the sessions which followed, that was of the two stalwarts of fire and building safety, Sri R.C. Sharma ji, and who is a former director at Delhi Fire Service, and Sri V. Suresh, who is the head of the Indian Green Building Council. Together, these two stalwarts bring more than a century of experience. R.C. Sharma ji briefed on the importance of Maintenance, utilities department to be well prepared to meet any unexpected fire. He also stressed on capacitating the staff, both medical and non-medical. Sri Suresh, in the second session, explained on the importance of code-compliant buildings and the important parts of the building codes, which enable hospitals in particular to be resilient and safe to withstand any unexpected calamity. Sir also touched upon the green building norms and the various ratings in this regard. Regulations and enforcement of it is also of prime importance. So this is a quick briefing of yesterday's session. Today we start with a keynote address by Madam Aparna Kanta. Aparna Kanta is a human rights lawyer who freelances with the University of Hong Kong and works on diversity, equity, and inclusion across the schools in Hong Kong. Passionate about human rights in disaster management, she has also done research in rights-based approaches to disaster management. Madam Aparna worked as a program associate with UNDP DRM program in India. She has worked in the Orissa super cyclone and as an NGO coordinator in a combined UN office, and also has assisted in the activities related to the Bhuj earthquake later on in Gandhinagar. She was associated with the Overseas Development Institute ODI in London also for a few years. With her versatile experience, I invite Madam Aparna to deliver the keynote address for the second day session. Welcome, ma'am. Over to you.
Thank you. Can you guys hear me?
Very well.
Yes.
And am I clear? Because I'm not wearing earphones. Is that okay?
It's fine, ma'am.
Absolutely clear.
Wonderful. Wonderful. So many thanks, Garima. Many thanks to GHI as well. At the outset, I really want to thank Geohazard Society and NIDM for treating me to this really well-organized and informative 3-day workshop. We still have the 3rd day to go. And on making hospitals functional during disasters, as well as managing them effectively in the context of DRR is a very important topic. And it's something that we have been struggling with. It's my privilege to be here with all of you and to see your efforts in creating an environment where DRR remains in focus and gets the much needed impetus that it deserves for the sake of all of us. I'm especially amazed about Jammu and Kashmir, the leaps in disaster management taken by the DM department and their partners from Amr Ali Saab's presentation yesterday. While I'm very humbled to be called an expert, I am very far from that. At best, I was a practitioner in a national program that was a pioneer in many ways, be it the framework or the ideology or the partners, stakeholders, the linkages, and the importance given to community-based plans. I am, of course, as you all are, passionate about disaster risk reduction and seeing an India that is resilient, sustainable, and prepared to face any disaster, if we can't prevent the hazard from becoming one, of course. We have best practices, successful pilots, and a pool of trained and experienced professionals in this field in India. Nothing really should stop us from achieving this. So I'm sure that all of you know about the Sendai framework for disaster risk reduction that keeps the Sustainable Development Goals or the SDGs of the UN in mind. This makes a clear mention of health and brings for the first time focus to disaster management in the health sector. And as mentioned yesterday, the National Disaster Management Authority has also come out with guidelines for hospital safety. What is prime for hospitals is not just safety, but according to what Hari said yesterday, functionality during disasters. Each hospital may from experience, may need to cater to many times their normal capacity during mass casualty events. Even meticulous planning and drills have to be done again and again. These are essential. Yesterday, we had mention of floods, fires, and earthquakes in the context of Jammu and Kashmir hospitals. I want to repeat what Hari said yesterday about hospitals being safe, not just for those inside, but being able to respond to those outside who need attention post-disaster, and being able to cope with all this without external help. He used the word functional. Is the building safe? Is the staff safe and prepared? Is the equipment safe? Has communication been possible? Electricity, water, oxygen, are they available? Are their suppliers unaffected? And can the hospital manage for 72 hours, as he said, without external help? Hours after the disaster, without external help, can they manage? Amir Sahab spoke about a decision support system for disaster risk reduction in Jammu and Kashmir. Clearly, disaster risk reduction and its management is interdisciplinary, and mainstreaming it into every service, education, training, and the need to practice all that together and then to regularly assess and update protocols and plans is absolutely essential. It's necessary. And this is not something that you don't know. I'm just trying to repeat what was said yesterday through the different sections. Let us now step back from hospitals for a few minutes and move up the line a bit. Along with hospitals, ambulances, and health as a sector in DRR, said the fire services, Mr. Asi Sharma was here yesterday, the police, the local government, civil society, etc., on the one hand. And then we have practicing engineers, architects, doctors, school, college, university boards, trained agencies such as the Red Cross, St. John's. And then you have UN agencies that partner with countries to build expertise, pilot innovative projects, and help to replicate good practices locally. And of course, we have the government at various levels. But why does all this happen? It's just a simple question. Why do we do all this? I'm sure you guys agree with me. It's to prevent disasters. And we all know what a disaster is, what an emergency is. According to the World Health Organization, a disaster is an occurrence disrupting the normal conditions of existence and causing a level of suffering that exceeds the capacity of adjustment of the affected community, whilst an emergency is a state in which normal procedures are suspended and extraordinary measures are taken in order to avert a disaster. All of us are familiar with the disaster management continuum. I'm sure I don't have to repeat that. Prevention, mitigation, preparedness, and then when the hazard manifests itself into a disaster, there's response and then there's recovery. In a developing nation like India, especially after the onset of the pandemic, this is a lot more important in the context of poverty that has increased by almost double. Hence, for us, to conserve hard-earned development gains, as in every developing nation, and to reduce losses to lives, livelihoods, and property in the aftermath of a disaster is really, really important, because otherwise we cause suffering to millions. So what is most important then? I just want to give you a slightly different perspective, because I am sure that the specialists who will talk after me will get back to details on hospital management. But I just want to talk to you about people or communities, their rights and their needs. To me, the rest is jargon. I mean, there is a lot of science behind disaster management. But as with any developmental issue and effort, the most important task at hand in disasters or in preventing, mitigating, or preparing to face them is to safeguard, protect, and promote the rights of people and communities, and to remedy violations to any of those rights. We know what rights are usually violated during a disaster. According to the UN, there is a list. Let me find that for you. I had it somewhere. Yeah. So the right to adequate housing, food, water and sanitation, health, work, livelihood, land, security of the person and home, information, participation, and education. Of course, much before this is life, right? And rights are given by law to every human equally, every Indian equally, to protect their fundamental rights, as so beautifully written in our constitution. There is poverty, hunger, disease, squalor, a lack of dignity, health, education. These are real issues. And then imagine what happens if we allow a hazard to manifest itself into a disaster, right? Yesterday, people were talking about the hospital in Jammu and Kashmir collapsing because of the earthquake, but then people reaching there and asking for help. What do you do in that kind of a situation? Should that situation happen, right? Now, the second thing I want to talk to you about is, while we discuss disaster management, can we ensure equality in access, which in a country like India can mean that you have to make some people more equal than others to achieve a balance. Women, children, differently abled people, those people who have been discriminated against on any basis of caste, religion, region, profession. We all know these problems at hand that have been inherent to our system. We've been struggling to be inclusive and fair. Not an easy task for sure, but we really don't have a choice, do we? Equality of all humans is a given. And by not allowing some to be equal, we're actually violating their inherent human rights. Every government's ultimate aim, really, as you will agree with me, is to safeguard, protect, and promote these very rights, such that every human in the country can live with dignity. Disasters in the past have shown us how selective the access to resources can be, even though we've had meticulous planning. Although there is enough written about how vulnerable groups need to be included, for instance, in the planning and practice processes, it is important to clearly understand that by doing so, we stay within the law of the land. We're not doing anything extraordinary. By ensuring that they have a place and they're safely protected is actually something that the law has to ensure. It does say it. So by doing this, we're actually just keeping within the law of the land. By failing these people in disaster risk reduction, we're actually violating their rights. And there will be, I hope, in the near future, ways to remedy these violations. People should be able to find out why they've been excluded. Rights-based approaches to disaster risk reduction are not new, and they contribute immensely to the success of any efforts in disaster risk reduction, and hence must always be kept in mind. It is against this backdrop of looking at disaster management as a right of a person rather than a good to do service by the government or civil society or volunteers or anyone, and the equity in disaster management being essential rather than a desire, we set the tone for today's experts and practitioners to interact. We have spoken about the Sendai framework. If I may, I just want to mention that in India, we have a disaster management act that many other countries don't have. We have a disaster management authority at the national level. We have more at the state level. And where we don't have, we have departments, we have the emergency operations centers. Then we have, of course, we have NIDM, which is awesome because they are actually looking at information, knowledge exchange, creating a platform. Then we have national plan, we have state plans, we have district plans, and then below. Right? So our framework is very robust in theory. And we have been getting better and better at understanding the needs of DRR as well. We have faced many more disasters since 20 years ago when I was in the country, and we have gotten better at dealing with them. But if we have to ensure that we conserve hard-earned development gains, especially in a way that they make the most vulnerable people more resilient, more confident, and their livelihoods are sustained in the face of a disaster, we have to necessarily tell ourselves that this is only the beginning. And we have miles to go before we sleep, in Robert Frost's famous words. And way more important than to have the right framework is to make it work. For all its components to work, rather than at cross purposes to each other, but with each other. The linkages must flow. If a local hospital is not part of a disaster management plan for a block, for example, or the women's self-help groups are not integrated into it, or the local school is not involved in the dry runs or the mock drills, as we call them, one can imagine that a plan can never really get real. Communities are the lifeline of their habitat, and awareness, education, planning, practice, mock drills, regular assessments, updating of the plans must all happen in a way that it involves them and puts them right above everything else. They are the focus. I'd like to say it is delightful to see GHS and NIDM taking such an active role in organizing events that train professionals in the field, encourage an exchange of ideas amongst partners, and most of all, urge the governments at various levels, their partners and civil society, to keep the focus on DRR. I'm amazed at the proactive role that the Jammu and Kashmir government is playing in this important task, including getting various stakeholders to participate and contribute, like here at this forum. I heard Amir Ali Sahab's talk yesterday, and he mentioned disaster management plans at various levels in the state and also guidelines for hospitals. That is awesome. I would love to know how they see a rights-based approach to DRR and how their various stakeholders connect to uphold people's rights in the context of disaster management at some point. Against this backdrop, I would like to now open the day's sessions for presentations and discussions. A dear ex-colleague shared a very important message this morning in the form of an animation. Climate change and the other disasters that are closing in on us. It is now a matter of do or die, disaster risk reduction. It likens inaction or insufficient, uncoordinated action from all of us to financing meteors to land upon us and make us extinct like the dinosaurs. I'm sure it's going around in the WhatsApp groups, and I hope that you guys have the time to open it and see it. It gives you goosebumps because it is so real. So let's please work together, work hard, and make a positive, substantial change. Take outcomes from trainings and workshops like this to make meaningful and practical action. Jai Hind.
Thank you very much, Aparna ma'am. That was
Thank
a very thoughtful and insightful presentation. I mean, talk from you. You could, I mean, we could see your heart pouring out, in fact, for the rights of the community and the people. And we really appreciate and we stand by the thought of yours, which says that disaster management is a right rather than a provision to be given by institutions to people and communities. We all definitely will agree to this point. And we would like to have you further in many of our further consultations as well, to bring about.
As long as you don't call me an expert, I'm happy to come.
Sure, practitioner, definitely.
But here I would like to intervene, Aparna. Although, I mean, you are more comfortable by saying former DRR and UNDP associate, but if you consider the kind of work you have done in UNDP for DRM, I don't think you are less than any expert, and the kind of speech you have given today, I don't think any expert can give much better than the one which you have given. So,
I'm very humbled. I'm very humbled. Thank you so much.
So you
second
can't deny
that.
the fact that since 2002, when the DRM was a new beginning in India, and many of us who were young and never worked in DRR field, guided by you, and you pitch in that how the DRM framework should be established in the state like Delhi. And you guided us in strengthening institutions, stakeholders, SDMA, how to be established, how to coordinate. So your contribution to this field is enormous. And we took so many successful initiatives in Delhi for strengthening DM institutions and capacities with ma'am. So I feel being very, great in her team and learning from her. Thank you so much, Aparna, for accepting my request to guide us in today's session and energizing us with your words of wisdom. And you spoke so nicely today. Thank you so much. I am highly obliged and delighted.
Garimaji, I second
I want to
that.
say something.
Garimaji, I second that. And I think that, we need to involve Aparna ji in our future programs also. I'm really impressed by the way she spoke and extempore and mentioned all the salient points that we had discussed yesterday, and really added knowledge to today's training program, in which there are participants from the districts. We have tahsildars, we have additional deputy commissioners, we have doctors, we have people from the civil society. They've all joined us, and I'm sure everybody will definitely get benefited from it. Thank you once again. Thank you from my side.
And I'd just like to say that while I was in UNDP with the program, it was really like a combined learning. I was new to DRM as well. So, Garima says that she learned from me. I have to say equally that I learned from her, from Hari, and all of us had this amazing person, Mr. Saroj Kumar Jha, as our boss above everything. And he was really an inspiration for all of us, for his hard work, for the way he thought, for the way he communicated, and for the immense difference that he made just to the way DRM was thought about those days. So I'd like to say it was as much a learning for me. Thank you, Garima. Thank you, Amir.
Thank you, Aparna. Thanks for coming. Yeah, over to you, Bhagwati.
Thank you, ma'am. Thank you once again, Aparna ji. As you rightly said, we require work more than frameworks. With this, I invite our next speaker, Dr. Purnima Prabhakaran, who is the additional professor and the head of the Environmental Health Center for Environmental Health. Trained as a physician in Bangalore Medical College, Madam Purnima has a master's in epidemiology from the London School of Hygiene and Tropical Medicine. And she has a PhD in social medicine from the University of Bristol, UK. Purnima ji heads the Center of Excellence for Green and Climate Resilient Healthcare Facilities at the PHFI, affiliated to the National Program for Climate Change and Human Health, the Government of India. She works closely with the UN organizations, including WHO, UNEP, UNDP, UNICEF, and for the various projects which she has been involved in. I welcome Dr. Purnima to take over. Over to you, ma'am.
Thank you. Thank you very much for the kind introduction. Good afternoon, everyone. I bring greetings from the Center for Environmental Health at the Public Health Foundation of India. At the outset, I would also like to accord my appreciation and congratulations to the organizing teams for hosting this very interesting workshop. I really regret not having the opportunity to attend yesterday because of a conflict, but it does seem like I missed a really rich interaction and all the deliberations that must have occurred yesterday, especially the experience from Jammu and Kashmir. I would have loved to hear that. So I hope I get access to some recordings. Can I just share my screen here? Is my screen visible?
It is.
Yes.
Yes.
Yeah. So the focus of this workshop, as I have seen, I was looking at the agenda, was building resilience of healthcare facilities. And that is such an important area for discussion, especially when we're talking about disaster management. At the end of the day, it's the healthcare facilities that become the community anchor. And I so related to what the keynote speaker, Ms. Aparna Kanda, was talking about, the people's lens and the community lens, because at the end of the day, it is the common man, the common woman who is affected, the vulnerable populations. And it is at the end of the day, the healthcare facilities that become the anchors for care. And as would all doctors know, we have to deliver care, and at the end of the day, become community anchors in the face of any event, any acute event. And here today, I'm going to be speaking and focusing on the disasters that are associated with climate change. And that's why my topic is titled Building Climate Resilience of Healthcare Facilities. I know that other topics were touched upon, earthquakes and other kinds of disasters. But climate change is becoming an increasingly important area because acute climate events seem to be wreaking havoc, not just in our country, nationally, but internationally. There's blurring of transnational boundaries because of this global pandemic. We have just kind of recovered. We're still recovering from one pandemic, the COVID-19, but right in our backyards, we have this other, slowly growing pandemic of climate change. And this is no news. It has become a common knowledge for everybody now. And we're increasingly hearing about acute climate events like floods, droughts, heat waves, rising sea levels because of melting glaciers as a result of global warming. And at the end of the day, again, the impacts on communities as well as on health is what we want to focus on. So building climate resilience of health facilities is the focus of my talk over the next 20 to 25 minutes. So, and why are we talking about climate change? It is slated as the biggest public health challenge of the century. We hear about many different hazards, but climate change is pegged as the biggest challenge of this century. And you can see here, whether it's the forest fires or melting of glaciers or, deteriorating air quality for people in the capital city of Delhi and NCR region and the entire Indo-Gangetic plain. We hear this is drawing room conversation now about deteriorating air quality. And this comes from the complete dependence we have on the burning of fossil fuels for our electricity. So generating electricity, 70% of that in India comes from burning fossil fuels in our thermal power plants. And this is one of the biggest culprits contributing to air pollution. So it's a very correlated kind of risk, air pollutants and climate pollutants. And so climate change becomes a very important area of concern for all of us. And it's also now the biggest public health opportunity because we know the reasons, we know why it's happening. Oftentimes it's anthropogenic, human-related causes that are responsible for climate change. So when we know the causes, it becomes a little easier to address the reasons for it. So we talk about it being also the biggest public health opportunity to act on. And what it relates to in terms of healthcare, climate change, it strikes at the very core of health systems. And health systems are here to provide care. What happens in these kind of situations? So whether it's floods like this in Chennai, December 2015, where patients had to be herded out of the hospital because the hospitals were not equipped to kind of withstand this kind of deluge of water. But look at somewhere else in the world. This is in South America, Puerto Rico, Hurricane Maria, similar scenes. And here, forest fires in California. So across the world, climate change is, I call it an equalizer. It doesn't differentiate between, developed and developing countries. The acute climate events are wreaking havoc across the world. And at the end of the day, health systems need to be prepared to address that. And in terms of what happens to our health in the event of acute climate events, when there is rising temperature, extreme weather events, rising sea levels, and increasing carbon dioxide levels because of global warming, the impacts on human health. And this exacerbates existing inequities. Mr. Parnakanda was talking about, the equity lens as well. It's a human right. Even in terms of the impacts of climate change on health, there is wide inequities in what happens. There are vulnerable populations within countries and across countries. Some regions of the world are more vulnerable to the acute climate events. In terms of impacts, it could be heat-related illness. It could be due to changing air quality, changing water quality, changing food supply. Also, climate conditions becoming more favorable for vector-borne diseases. So mosquito-borne diseases like dengue, malaria, chikungunya, these are becoming more and more common in some parts of our country even, which have not seen these diseases before. And all of these are pegged down to the changing climatic conditions, which become more favorable for these conditions. So at the end of the day, our health systems are going to be plagued by a surge in disease as well. So are we equipped to handle that increased disease burden? And last but not the least, again, an equity lens. There's forced migration as a result of acute climate events. There's going to be civil conflict. There's conflict for food, conflict for healthcare access. So the impact of climate change on human health exacerbates actually existing inequities. So in terms of health, as a public health person, I would certainly talk about what it means in terms of health burden. So globally, climate events are projected to cause an additional 250,000 deaths per year. That could range from the impacts on our agriculture, farming. India is an agrarian economy. A large part of our economy comes from agricultural practices. If we are going to have storms and droughts, it's going to impact our food production. And at the end of the day, our food security and nutrition security, vector-borne diseases, waterborne diseases, heat stress. And at the end of the day, it's indirect cost to our health and our economy as well, pegged at something like $2 to $4 billion per year as a result of acute climate events. And the weather-related disasters are only increasing. And many developing countries, including India, do not have well-equipped health infrastructure to handle this surge. So that's where the concept of health sector becoming resilient to climate change also comes. And in terms of the economic costs, India is well ahead of even countries like US and Saudi Arabia in terms of loss per ton of carbon dioxide that is emitted from the country. So the implications of climate change for India cannot therefore be understated. So where does the health sector role come here in terms of response to climate change? So some of us, or most of us, are familiar that every year we have the Conference of Parties, the COP meeting, where climate negotiations happen. We have the next one starting in a few days from now. And in 2015, there was a call for aligning healthcare with that Paris Agreement, which was a commitment by all UN nations to prepare themselves to handle climate change. And there was a call to mobilize the health sector to become a leader in responding to climate change. How do we do that? What is happening in India is what I want to next talk about. So there has been action in India as well for developing health sector resilience for the response to climate change. Way back in 2008, there was the Prime Minister's Council on Climate Change, and there were about 8 missions over there. You will see that there was no discussion around health. It was only in 2015 that the health mission came into focus, it was established, and thereafter there has been action. And today we fortunately have a national program for climate change and human health. And within this program, there is a framework that is being developed for all health sector actors to respond to climate change and become resilient. And within the program, there have been centers of excellence because we recognize that it's a very intersectoral response that is required for climate disasters. So whether it's vector-borne diseases, I mentioned some of it earlier, air pollution or nutrition, mental health, a very important one. All of these institutions have come together under the Ministry of Health to develop the response framework for the health sector as a response to acute events. And we at PHFI are recognized as the Center of Excellence for developing a framework for climate resilient and green healthcare. And I will come to what that means. Before that, I just wanted to highlight what are those guidelines generally for developing health sector resilience. It is a central response. Health has to be in the center of all our policies and frameworks. If we have good health, we are well positioned to handle anything else. And we saw that now in the COVID pandemic. If we lose our health situation, we are not able to respond to any other acute event. In our response, we have to align with global frameworks and guidelines, but we have to recognize that India is a very diverse country. Every state is different. We describe ourselves as countries within a country. And so we really need decentralized action at state level because every state has a different climate vulnerability. We have states like Orissa that are vulnerable to floods, whereas a Rajasthan or a Gujarat that are more vulnerable to heat waves. So depending on our climate vulnerability, the state needs to develop a customized response for its health sector. One size does not fit all. So a vulnerability risk mapping needs to be done, and each state has to recognize what its climate vulnerability is before it develops the response. So in summary, what links climate change and healthcare is that we have to recognize that there are impacts of climate events on health. We're going to have a growing dependence. Communities are going to depend more and more on healthcare services. And we need the capacity. If our health sector does not know about climate change, they don't know what the disease burden that is going to come with the acute climate events, we're not going to be able to articulate a response. And so really, are we prepared is the question. And many times I think the answer is no. And so really, this is a wake-up call to all of us. When we talk about actually how to respond and develop our climate resilience within health systems, we did talk about 6 building blocks. First of all, we need leadership. We need some good peer leaders, some champions, and of course, the political will and the governance structure. Second, we need a health workforce. We in India still have a very poor doctor-patient ratio. We don't sit anywhere near the WHO guidelines. So we need a health workforce to respond. We need good information systems, good medical products and technologies. We need good service delivery chains. And of course, at the end of the day, health financing. The percentage of investment in health in India is 1.2% of the GDP, minuscule amount of investment that goes into health, and that's really got to change. So in terms of response, we see that the 6 building blocks that I shared with you are really what we need to develop our climate resilience. If we have these 6 building blocks, we can develop all our operations around this. And this includes things like early warning systems, vulnerability risk mappings, our technology, as well as our preparedness and response based on good climate financing. So the concept of climate smart healthcare became relevant in the year 2017. And this was as a result of work done by an international group called Healthcare Without Harm. We deliver healthcare, but we need to do that without causing harm. And this report was published in 2017 by Healthcare Without Harm with World Bank. And they talked about 7 important areas. One is overall health system design. We need coordinated care. We need to be available for the communities, and we need to be driven by the local public health needs. Like I said, every state has different health needs. We also need structural and functional resilience. So we heard that, I know Mr. Hari always talks about, we don't need just structural resilience. We don't need just strong buildings, but we also need to be functional. So while building design and construction is important, we also need to make ourselves functional. And some of those things can come from, strengthening our energy efficiency. We can think we are a very endowed country in terms of solar. Solar power can be a very clean form of energy and also a continuous source of energy supply for our healthcare facilities. So there's other areas that a health facility has to think of. If we're inundated by floods, the healthcare waste can become a very, very hazardous source of further infections. So we have to also focus on our healthcare waste management. Sustainable transport, how we optimize our water consumption, and overall procurement policies for our pharmaceuticals and all the things that we need for delivering healthcare has to be very, very consistent and sustainable in our approach. And resilient strategies to withstand extreme weather events and anchor sustainable communities. Again, these are the 7 hallmarks of developing resilient climate smart healthcare. And this is the report that I was mentioning. The other aspect of being climate smart, which might be new to some people, is how healthcare should not also be contributing to global warming. So we talk about healthcare's own climate footprint. We talk about all the healthcare facilities in the world together contributing about 5% of carbon dioxide to the global greenhouse gas emissions. And that is something which is not expected. Healthcare sector should also become environmental friendly. So this is the other concept of being climate smart in our healthcare delivery. So just to put that in perspective, when we talk about the climate footprint of healthcare sectors, it equals something like the emissions from about 500 coal-fired thermal power plants. That's the amount of emissions that comes from healthcare. So that's a staggering figure, and we really need to see that our healthcare becomes green. I'll go through this quickly. Actually, these are the different components of healthcare that produce, greenhouse gas emissions, and a big part of those emissions come from our supply chain. So we really need to become sustainable in how we procure our medical goods and pharmaceuticals. We need to reduce our footprint across the supply chain. And in India, the greenhouse gas emissions is something like 39 metric tons of carbon dioxide, which is huge. So I just want to conclude by talking about our work in the Center of Excellence. The concept of developing climate smart healthcare for India will talk about 2 important pillars. One is what I was talking about earlier, which is developing our capacity to respond to the surge in diseases that are going to occur. And that is the concept of climate preparedness or adaptation of the health system. The other pillar of climate smart healthcare is mitigation, which is, reducing our footprint, reducing our carbon emissions within the healthcare delivery. And why do we need this? Why do we need climate smart healthcare systems? Is because healthcare facilities are really the first responders. Like I said, they have to be the first responders in acute events. They also have to be the last building standing. You cannot afford the health system to collapse. You need to be standing, you need to be functioning and delivering uninterrupted care during acute events. And for that, you need not just robust infrastructure, but also to build our capacity and that of our personnel as well. And this is the definition that WHO has, for climate resilient health system, one that is capable of anticipating, responding, coping, recovering and adapting to this climate-related shocks and stress so that you bring sustained improvements to your community's health, despite whatever the climate. So that is the definition of WHO. And together with that, the other pillar of reducing our carbon footprint is the mitigation component of climate smart healthcare. And more than half of our healthcare footprint comes from its supply chain, as I mentioned before. And again, the definition that WHO has for mitigation or greening our health system is that we have to reduce all our emissions from across our supply chain and become very sustainable. Together, these two, the resilience as well as the mitigation aspects of healthcare, build a climate smart and a resilient health system that can adapt for delivering critical healthcare services whenever there is disaster. In India, this is a huge challenge. For those of you who are familiar with the health system in India, it is not like one health system like in the UK. You have the national health system. We have private hospitals, we have public hospitals, we have the Ministry of Defense, we have the Railway Ministry. All of them have their own health system, structure. And so we are talking about bringing about a change, building resilience across this entire network of hospitals, which is a huge task. It's a tall order. But hopefully we are kind of set out there through the national program, and we are going to be working with all the states to develop the climate resilience of the healthcare facilities down to the PHCs and the new health and wellness centers as well that the Ayushman Bharat program of India is looking to do. So I will skip these. These are actually different steps that I mentioned earlier as well, that first we need to identify our risks and vulnerabilities, and then build our capacities to respond to the acute disasters. And every state is building their own framework based on their risk assessments. And so hopefully every state will be having a good response to climate change in the years to come. And really, I talk about this framework as 10 pillars within the India framework that we are developing. We are talking about all these aspects. Selecting the site, I'm sure Mr. Hari has referred, or will be talking about this next. Even selecting where your healthcare facility is going to be is so important. Building an infrastructure, optimizing our use of resources, our handling of the healthcare waste management, transport, getting connected to communications, to early warning systems through meteorological department. Unless we know what is coming, we probably won't be well prepared when the response is required. Of course, human resources, awareness and knowledge. Everybody needs to be aware of what is to come. Good leadership, climate financing, at the end of the day, intersectoral coordination. So I'm going to just show you so this is the framework that we are developing. So we have examples already. This is a PHC in Chhattisgarh, which is already has solar power, because it has been shown that if you have a continuous supply of electricity in the face of an acute event, you're not going to have interrupted energy supply, which will affect your health outcomes. And there are private hospitals as well that have taken important steps towards this resilience and adaptation. This is just a peek view at some of the framework that we have given now to the states for their action plans across all the different domains, from site selection to energy to lighting to buildings. We have given them various action points and how they should be coordinating, who are the stakeholders they should be engaging with, and the different resources that are available for them as they go through this exercise. So water management, waste management, how you establish your procurement practices, linking for your climate information services, awareness, and capacity building. And we have also guidance from international organizations like the World Health Organization, again talking about the same pillars: health workforce. We need good water, sanitation, hygiene, and healthcare waste management. We need very sustainable energy services to ensure uninterrupted functionality. And at the end of the day, infrastructure and technology comes to the rescue oftentimes, decision support systems. I heard the mention somewhere. So I think all of these guidance is also now available to help health facilities to become resilient in the face of acute events. And the key word now is climate smart health systems, which is a smart strategy for future healthcare. And it cannot work alone. The health sector needs action across the public works department, the energy department, the fire teams, the hospital safety teams, infection control. So intersectoral coordination is key. So that's a whistle-stop tour of what it takes to develop climate resilient health systems. And I'll be happy to take any questions. Thank you.
Thank you very much, ma'am. That was a very insightful presentation where you touched upon the building blocks and the key elements of climate smart health systems, and how you have touched upon the various dimensions of making the climate resilient hospital infrastructure climate resilient, as well as adopting the green practices. I would urge the participants to pose any questions if they have on the chat box.
With your permission, I'd just like to say something to Purnima ji. Is it okay?
Yeah, sure, ma'am. Please.
Yeah, okay. So at the outset, I want to say amazing presentation. And the more you hear about it, the more daunting it seems. How will you ever integrate all these myriad levels of healthcare systems in India to make any sense of it as a national plan or as a state plan? So, and I know what happened during COVID. I mean, we had no clue about beds, about medicines. We didn't have enough doctors. We had ventilators, we didn't know how to use them. I mean, I personally have had doctor friends saying we were forced to get in and start operating them. But between the two waves, nobody ever told us how to use them, as a preparedness measure. We do know, and we don't have to get into, what happened then. It was crazy. It was traumatic, to say the least. And 1.2% of GDP, I mean, I think that's shameful, if you ask me. But I just want to know from you, Purnima ji, is there a protocol or a document that a hospital can use to assess its disaster risk in India, given by the government, at the center or at the state? And is it mandatory for a hospital to use it?
So there isn't a protocol. It's all work in progress now. So within the national program, there are several, institutes of expertise that are working together. So to develop, the risk assessments, the vulnerability assessments at every level of healthcare, there are guidelines being developed, and those will become what the protocol will be at the end of the day for every level of healthcare. And every level of healthcare, down to the PHC and the sub-centers, they are very different in their structure, the services that they offer, the personnel that are involved. We go down to, a no-bed kind of a sub-center, and then going up, you go to district and sub-district hospitals. They could be anywhere from 100 to 500 beds. So the response and the preparedness also differs. But there is a move towards that. There's a whole lot of training and capacity building that is going on through the national program. Several trainings, where every state is attending, and all their district officials, the PHC and CHC officials are all attending. They're becoming increasingly aware of the climatic disasters and how they should be preparing to respond to it. In terms of vulnerability assessments, there are individual components that are going on. For example, energy assessments, the water assessments, in terms of the building structure. So there is no one protocol. So as you realize, like, it's very different domains. So, the health experts are not necessarily building experts. So it takes that very intersectoral kind of response to come together. It's a huge challenge, but at least something is started, and I'm sure soon
So we still don't have something that a hospital superintendent can be given, saying, here is your list, and can you go and check if you're safe? And if it involves engineers or architects or whatever, get them involved. But can you tell us whether you have a certain
there are checklists now that are being handed out, and but yeah, it's all work in progress now. The program itself is just 3 years old, and I think it's taken, how things will start. And
there are no pilots. There is no pilot.
So we are involved in some of them as well. So there have been some assessments in some states as well. We are getting into the ground now in some of the states, in Karnataka, in Orissa, in the Northeast, in Madhya Pradesh, and starting to do some baseline assessments to help them then move forward with that.
Wonderful. Thank you.
We have a question in the chat box related to the emphasis on telemedicines in the COVID scenario. There has been much emphasis about telemedicine network across India. What I want to know is, has COVID provided us the chance to upgrade our capacities vis-a-vis telemedicine? And if so, up to what extent?
Yes, it's true that I think especially during COVID, there was increasing transition to a different form of health access. Like, people could not go to hospitals, so telemedicine became the key word. But yes, think about all the remote places where people don't have access to internet. So how do they even access telemedicine? So there isn't like a national program for telemedicine, but yes, at least in PHFI, we have started experimenting with something called assisted.
I request all other participants to kindly remain on mute, please.
So the concept of assisted
You can come in.
Yeah, the concept of assisted telemedicine is becoming, more and more popular, where, the remotest of populations are facilitated to access healthcare by having a one-stop shop where there is at least one doctor, one nurse, and some kind of access to telemedicine, and they are helped to access care. So this is kind of helping to fill the gap between the patient and the healthcare provider. And the other kind of approach has been task shifting, where you don't have doctors, but at least you have people who are trained through the use of mobile platforms, for example, decision support systems. So there are newer innovative models of healthcare delivery. And I think soon, I hope those things will be scaled up in other areas of the country as well. We have piloted it now in a few states. In Tamil Nadu, we are looking at Karnataka. We are looking at some states in the north as well. So assisted telemedicine soon should become a reality for all these states.
Thank you very much, ma'am, for your response. We have one more question which has come up in the chat box, which is asking about what should be the role of a hospital chief to reduce the carbon footprint. If I were a hospital chief, what can I do to reduce the carbon footprint? That was the question.
Thank you for that question. So I would also urge you to connect with me individually as well, because we are kind of already doing a lot of work in this space, handholding hospitals who are interested in this. We call it a climate impact checkup tool, and we are helping them document a baseline of their carbon footprint. It takes a little bit of hand-holding, but we do work with a network of private hospitals in India, and who are all building their capacities for environmental awareness in the broad sense of the word, but also signing up to this activity of reducing their the carbon footprint. So I'd be very happy to walk you through some of that, and my team will also be available to help you. Thank you.
We're extremely thankful, ma'am, for your response as well as for your time. And we are also thankful to the participants for raising these questions, relevant, pertinent questions, in fact, which has, importance in this time of COVID. our next speaker, ma'am, if we have some questions towards the end of the session, maybe will you be available, Purnima ma'am, to address it, or towards the end? Because we did take some questions now. If at all we get some questions towards the end of the session too, I just wanted to confirm your availability.
Yes, I will. Yeah.
Yeah, ma'am, Purnima ma'am, this is Hari. Ma'am, there is no pressure. I know you are very, very busy, and we are very, very grateful that you gave us the time. So we can actually send you the questions and request for email answers. That also is fine. But I would be happy if you remain or come back towards the closing.
Yeah, I'll be here for some time. So I'm actually traveling tonight, so I
know.
Back to the climate meetings. So
Ma'am is going to.
So I'll be here for some time.
Yeah. Okay. Okay. Thank you, ma'am. Thanks a lot.
Thank you. But I'll be happy to take any questions on email if you have any from the participants. Please, and you can share my email, and I'll be happy to respond. Thank you.
So we have our next speaker here with us, Dr. Hari Kumar. Hari Kumar sir does not need any introduction to the panelist over here because he has been their colleague since his UNDP years. Sir has 34 years of experience in the disaster risk management and disaster risk reduction field with safe shelters, and sir has a PhD in architecture. He has been heading Geohazard Society and has been instrumental in encouraging hospitals in India, Nepal, Bhutan, and lot other South Asian nations to build in resilience and to build in preparedness in the hospital and the health systems. Over to you, Hari sir.
Thank you so much, Bhagwati. Thanks a lot to NIDM and especially the most important partner from J&K. This Amir Ali Saab, you and your organization has brought in so many very important stakeholders into this conversation. I'm so grateful that they are all present. So I'll sort of continue from where we left off the discussions yesterday. We were talking about hospital functionality, and as both Aparna ma'am and Purnima ma'am said, about the need to understand what all can happen is so very, very important. So I really think that understanding risk is very, very key in starting the process of disaster risk reduction. And yesterday I started with a question about whether the hospital should be safe or functional. And today I will start with another question about disaster management or disaster risk reduction. I mean, earlier we used to say when Dr. Garima, Aparna, we were all working together. We really thought we were working in disaster management till we started working towards reducing the risk rather than trying to manage. The term disaster risk reduction actually stems from the earlier use of the phrase disaster management, because it sounded like there has been a disaster and we are trying to manage it, and that was what it was in the year maybe 1990s. Aparna was talking about the Orissa super cyclone. Even then, even the super cyclone, the cyclone happened and we were trying to manage it, and I think that phase went till the Gujarat earthquake, when India as a country decided that we need to be proactive rather than reactive, and look at things we can do before to prevent the impacts becoming more than we can handle. So disaster risk reduction any day, but what is the risk? Also, we need to really understand before we talk about trying to reduce the risk and trying to reduce the risk in hospitals. The understanding of what all constitute risk is really important. And you look at the the countries and the earthquakes. I mean, we're just looking at the case of earthquakes here, and we see that USA has had 6.2, 7.3s, and the numbers are really 2, 3, 2, 60. Northridge earthquake in 1994, 60 people, out of whom about 50 of them were trapped in a bridge. It was one incident. Other than that, it was quite a handful. Yeah. And look at Japan. You have 8.3s and nobody dying. Kobe, of course, had a lot of casualties, 5,000 odd casualties. And Kobe had also brought in a lot of learning for the Japanese. And that is one thing I think which differentiates the Japanese from the rest of the world, is that they learn from their disasters. They learn from what happens, not just what happens to them, but also what happens outside. I mean, if you look at the history of Japan's code revisions, there are certain events which have triggered code revisions. 1923, the earthquake in Tokyo. There have been several events which have triggered changes in building codes. And then, interestingly enough, the Northridge earthquake in the US also brought about code revisions in Japan. That is what is so good about countries which are ahead in the preparedness part, ahead in the thinking towards disaster reduction, because they learn from their own events and they learn from things which happen far away from them. And compare that to us. I remember the 1990s, Andhra Pradesh had 70s, 80s, and 90s actually, early 90s. Andhra Pradesh used to be battered by cyclones, and similar was the case with Bangladesh, battered by cyclones. And in 90, there was Andhra Pradesh started a new program for reducing cyclone risk. And they had cyclone shelters built in, community preparedness activities started. The neighboring state of Orissa hardly looked at what is happening in Andhra Pradesh because, no learning. Till 1999, October 29th, coincidentally, we are very close to the anniversary of the Orissa cyclone. Till that happened, Orissa was not even beginning to prepare for disastrous events. And after the cyclone happened, Orissa suffered. I don't know, but 15 to 20,000 people died in that event. And then Orissa became the leader in disaster preparedness. OSDMA was formed even before the national MDMA was formed. OSDMA was formed, and they started taking huge strides after the event happened in there. They did not learn from others, but at least they learned from themselves. Similar is the case of Maharashtra. Latur earthquake happened in 1993. Every district of Maharashtra developed a disaster management plan. I would call Gujarat a neighboring state of Maharashtra. The lessons learned from the Latur earthquake in Gujarat, zero. Took the 2001 earthquake, then suddenly Gujarat became the leaders in disaster preparedness. Can India wait for every state to have its own major disaster before India gets prepared? We need to learn. We need to learn from others. That's really, really important. So here the discussion is on, is risk uniform? And we see that in the US and in Japan, the numbers have been really less when, earthquakes like Uttarkashi 6.6, 2000, Latur earthquake, which I just mentioned, 6+ magnitude earthquake in a rural area. Latur is Kilari, it's a rural area, and we lost around 9,000 people. So the similar events are creating more losses in one place. So risk is not uniform. So I would like to compare two cities, one city in one of those two prepared countries and another in one of our cities. And if the same intensity of earthquake happens in both of these cities at the same time of the day, and let us imagine that the populations are the same as well, the results are not going to be the same. And what is different? What is different between that city in Japan and that city in India, somewhere in India? What is the difference? What do they do different that we cannot do? What is it that increases the risk at a place? So one thing is hazard. Hazard is any event which can potentially trigger a disaster. An earthquake in itself is not a disaster. If like the earthquake 8.3 we saw in the last slide in Japan, where no one died, did not become a disaster. But if the same thing happens in another place which is not well prepared, that can become a disaster. So the hazard event itself is not equal to disaster. It is something which can potentially become a disaster. Then we talk about vulnerability. And most of the vulnerability, we discussed vulnerability yesterday. Suresh sir gave a lucid presentation on the vulnerabilities of our built environment, what all vulnerabilities are there. And that is the vulnerability of our buildings. Are we building them to code? Are we following the code in whatever we are building? And the type of building. Latur, actually, it was the material of the building. It was large rocks which were used in construction of these rural dwellings, and stone slab roofs, which actually proved the killer there. And ages. You build something, a hospital, but the maintenance is always taking a backseat. you need to spend on maintenance also. So this is what the vulnerability of the built environment could be. It could be something like this. If you look at the picture on the left is from an earthquake in Uttarakhand, and on the right are two pictures from Gujarat, the Bhuj earthquake. You can see so-called engineered buildings, multi-story, tall buildings, which have failed in earthquake. And the one below is a school which collapsed, killing 30 children on Republic Day. Engineered building again, suffered a pancake collapse, where it's called a pancake collapse because you only see the slab above slab above slab. It's almost like a pancake. There is no evidence of the columns there. And this is the kind of vulnerability sometimes we built in. And our hill towns, because our friends from Kashmir are here, I would like to talk a little bit about the vulnerability of our hill towns. You look at this, it's not Kashmir, it is from the northeast, but you look at the vulnerabilities which are being built here. There's not a spot left for construction there. And if there is no construction there, it is because it is a cliff. That is the vulnerability of the built environment which we are doing. And none of these buildings, this is Aizawl for you, this is Aizawl, the capital city of Mizoram. And you can see, these are not small buildings. These are 10-story buildings, 8-story, 10-story, 12-story buildings. And there is no space, even, the proverbial needle, we can't even put a needle in between these buildings. And you can imagine, if a reasonable size earthquake happens, do you think people can evacuate? Where do they evacuate? And one of these buildings falling down is going to have a domino effect on several other buildings built below. And how are these buildings built? I'll just show you a glimpse. This was when I visited a site of a new construction, and the person who was constructing this has cut into the land below the house above, and he has actually knocked off the foundation of the building above. It is lying on the ground here, and probably while he is constructing, he will join it back and probably give a band-aid around it or something like that, because you cannot connect a foundation back to a building, and the thing is, the person living above does not have any problem with this because he himself has cut the foundation of the house above him. And that is how hillside constructions are. And I've seen in Kashmir also a lot of such similar kind of towns developing. I was part of the team which did the assessment after the Doda earthquake, and on the way to Badarwa and all that. There were so many similar, I was thinking of mini Aizol's in the making. And we are building in vulnerabilities. A very sad picture from the Nepal earthquake, where, it says school area drive slow, but there isn't any school there because it's all down. And the lucky thing about the Nepal earthquake, the only lucky thing about the Nepal earthquake was that it happened on a Saturday, holiday for the whole country. Actually, Saturday is the only holiday for the country. Just imagine if this 6-room school building was occupied during the earthquake. Let us assume that each class has 50 kids. You're looking at 300 families who are going to be affected by this. Just luck. So vulnerabilities is not just to our buildings. We are also looking, when we are talking about hillside towns and places like J&K, we are looking at access, the road also. The vulnerability is not limited to the buildings, the built environment, but also to the services, the roads. So this is from Himachal Pradesh, Kinnaur, and you see it's just a rock fall, and it's probably one rock, but you can imagine how much time will it take for this road to be cleared before services can be resumed. And imagine if people living above are dependent on this road to be functional for any rescue or relief. That can happen, and I'm sure there are many towns in J&K which are connected by just one road. So when we're looking at vulnerabilities, we are looking at not just the buildings, we are also looking at the vulnerability of roads. And roads actually are not just roads, because roads are the alignment along which you take your communication cables, you take your electric cables, there are water lines going along the road. So you lose a road and you lose many of these services. All of these. So vulnerability is a combination of all of these, not just the built environment. And then we talk about capacity. The next item, the thing which can affect the risk at a place. We always say that the Japanese are well prepared, and it is their capacities are high, and capacity is the resources of the community to cope with the threat of a hazard. So an example from Afghanistan, there was an earthquake in 2015 where I learned that in a school 12 schoolgirls died, and I was thinking it is the building that collapsed. But when I read more, I realized it was not the building. The building did not collapse. It is just that when the earth shook, the girls, they panicked and they ran down the stairs through a narrow stair which was near them, and one child fell down, and several fell on top of them, and a stampede, 12 girls were lost. So if they had a disaster preparedness plan, they would know that during an earthquake is not the time to run. During an earthquake is the time to do a drop cover hold. And after the earthquake, you have to evacuate as per the plan. So there are staircases assigned for each classroom, and you're supposed to keep to the right or to the left. If there was a plan, they wouldn't have run. If there was a plan they had practiced, they wouldn't have died. That is capacity of the people. So we need to bring them, all these elements together: hazard, vulnerability, capacity, and then the last point is risk, which we are trying to reduce here. And risk is the probability or the likelihood that a disaster turns into a hazard turns into a disaster. And the UN has done a good job in connecting these elements: hazard, vulnerability, and capacity. and risk. So hazard into vulnerability divided by capacity is equal to risk. This is not E is equal to MC squared kind of equation. No, this is only a way of us understanding what are the factors that can affect risk at a place. And if you look at this equation, do we have any control over the hazard? Can we stop the earthquake from happening? We can't. See, we have only control over vulnerability and the capacity. If you want to reduce risk, you need to bring down your vulnerability. Bring down the vulnerability of your built environment, your roads, your electricity, your water supply, all of those, which is key for continuing life as it is, continuing the functionality of the city and your hospital. The vulnerability has to be brought down and the capacity has to be built up. Capacities have to be, that involves preparedness. And if I look at this from a hospital's point of view, vulnerability is to do with your building. Vulnerability is to do with your utility services, electricity, water, and all that, air, or all of the services. And capacities is whether you have a plan, whether everyone is trained, are you doing mock drills, do you have a triage plan for events that happen in the daytime, plans for events that happen in the nighttime, all of that capacities. Then if your capacities are high, then your risk is low. So similar, I was saying, similar is the case with two hospitals. And we look at health facilities, disaster risk reduction. We need to increase capacity of everyone. It's not just the doctors and the nurses who need to get trained. Everyone has to get their capacities built. Everyone has to understand the risk they are facing, what all can happen in my hospital, and how I can play a role in reducing that risk. So training of doctors, nurses, paramedics, engineers, everyone has a role in disaster preparedness in the hospital, and decreasing vulnerability. If you're building a new building, make sure it's built earthquake resistant. The codes mentioned by Mr. V. Suresh yesterday should be followed. But the NDMA guideline now says for critical buildings, you need to go beyond the code. The following the code is not enough because the code ensures safety. Code does not ensure functionality. When you need your buildings to be functional, you need to go beyond the code. That is what the NDMA guideline for hospital safety mentions. And you have to choose which are your critical buildings. That is one thing, which are your critical services. Because that is something we really don't understand, that we don't really focus on. Because I go to several, do assessment of many hospitals, and these hospitals, I mean, I'm thinking of a hospital in Bihar, in rural Bihar. I went to a hospital which was built by the British. And when it was built, it was a whole hospital in itself. There is one building, it had the emergency, it had the OTs, it had some ICUs. All of that was there in the old building. It was a very old masonry building, not earthquake resistant by any means. And when they got money from NRHM, they built a new, they had to build a new ward, female ward. They got more money. They built an oncology block. They built a nurses quarters. All of those was built around the whole hospital. And all of those new buildings were earthquake resistant, built earthquake resistant. Bihar PWD ensured that. But just imagine what would happen if there is an earthquake now. The main building would not be surviving, which means your emergency, your OTs, your operation theaters, operation theaters, ICUs, your CSSDs, they are not going to be functional. Yes, your oncology department will survive. Your nurses' quarters will survive. But that is not what really you want. So you need to invest in safety. You want to understand which are your critical services, and you protect those services. So if you are building something new, try to move your critical services into those new buildings, because you want to protect your emergency department at all costs. You want your OTs to be functional. Move them to new earthquake resistant buildings. And in existing buildings, you may have to retrofit. That old building which I told you in Bihar needs retrofit. It may not be, again, retrofitting also, retrofitting a hospital building may not give you a functional building. It will give you a safe building. It will give you a safe building, but it may not give you a functional building. For functionality, you need really to invest in new buildings. So move your critical functions to better buildings and retrofit the old structures to services which may not be so critical. The last part is the non-structural mitigation, very, very important part of hospital safety. We will talk about it in detail tomorrow. Hospitals are particularly at risk, and we have seen many health facilities have failed in previous hazardous event. They need special attention because of the vital functions they perform, the high level of occupancy, people who are already in there, and the role they play during the disaster situation. During the golden hours, the role of the hospital is very important. But we have failed in many times, in many disasters, we have seen hospitals fail. 1971, right from 1971, Veterans Hospital, the San Fernando earthquake, complete collapse. Mexico, 1985, San Juarez Hospital, complete collapse. And 1,200 people died in this. I mean, forget that the hospital was not available, but it killed people. Northridge earthquake, many hospitals collapsed. USA started looking at hospital safety only after this event, the 1994 Northridge earthquake. The hospital's name is Kaiser Permanent, but this doesn't look very permanent to me. It doesn't look so permanent. The Oliveview Hospital, 1971, the building suffered, and they built it back. But again, in 1994, this hospital building was affected due to non-structural risk, because the fire sprinklers, the building was good in 1994 when they built it. They said they built it like a battleship, but the fire sprinklers actually knocked against the false ceiling. They all started leaking, flooding the hospital, and they had to evacuate the hospital. And we have our own example from the Bhuj hospital, the Jubilee Hospital. Kutch is one of the largest districts in the country. It's bigger than some of the states we have. It's bigger than the country of Bhutan. And this, at that point of time, during that earthquake, we had one major hospital, the Jubilee Hospital, which mostly collapsed in that earthquake. So when people tell me that 13,905 people died in that earthquake, I think maybe if this hospital was functional, some of those may have been failed. The hospital remaining functional is so key for saving lives and limbs and health of people. Iran, an earthquake in 2017. And this was the description of what happened in that earthquake, the things which were underlined. Elevators got stuck, ceilings collapsed, false ceilings collapsed. And when false ceilings collapsed, I saw in Bhadarwah Hospital also during the Doda earthquake, false ceilings collapsed. There were lots of false ceilings coming down. And when in an operation theater, even if one tile of the false ceiling falls down, it brings down years and years of dust. So your sterile surroundings are gone. So false ceilings are really important, and making them earthquake resistant is important. So here elevators got stuck, false ceilings collapsed, floors jumped like springboards, and patients had to be evacuated. And the hospital's director said his ceiling swayed and the cupboard started dancing. And there was nothing the staff could do but evacuate bedridden patients. Evacuating bedridden patients. A patient is in hospital because he is sick. So if you make somebody in the ICU, in critical care unit, evacuate, that means you are compromising on the safety of that person. By keeping him inside, again, you are compromising because the earthquake You don't know what will happen in the earthquake, but you are compromising on the treatment when you are evacuating people down to the ground. That evacuation, the patient is more likely to be affected seriously, become more serious after the event. So, do we really understand what all can happen in our hospital? Do we really understand our risk? It is important to understand what can happen, and it is important to understand what all can happen. In our region, we are, of course, India is an earthquake country. The Himalayas are an earthquake country. Landslides, common, rockfalls, common, floods, cyclones, tsunamis. What else? I think India is prone to almost every hazard there is. And you know, except for the coastal ones, J&K also is prone to most of these, all of these hazards, and plus avalanches and forest fires and many more. The last question, what else is very important? As a hospital administrator, you need to ask, what all can happen in my hospital? It's very, very important. You know, the local hazards are very, very important to include in your disaster management plans. So our region is prone to many things. We'll look at a few of these hazards. We already talked about fire yesterday. So what are we preparing for? What all can happen in and around our hospital, which can affect the hospital, and what can affect the community that the hospital serves. If something can affect the community, that is going to bring in a lot of patients to us. So we need to understand that also. What can affect the hospital and what can affect the community. Consider all those hazards. So we have excellent maps showing what all can happen, state level maps, sometimes district level maps as well. So this is the wind and cyclone map and the flood hazard map. The flood hazard map also shows the storm surge hazard in each state. The landslide hazard zonation map for North India, Northeast India, and South India is also available. The earthquake hazard zones, this is available in app form now. You just have to look for BMTPC's India earthquake maps. Search in Play Store, you can download the maps and you can go right up to district level maps for earthquakes. And J&K is actually crisscrossed by faults. We are right at the plate boundary, and hence you know, look at the kind of faults that are in and around us. We are at the plate boundary, and we are likely to be affected by earthquakes. And when I say plate boundary, what are plates and what are plate boundaries? The outer layer of the earth is made up of several pieces called plates, and these plates are constantly moving against each other because these are floating on molten magma below, and these are constantly moving against each other. Some are hitting against each other, some are sliding against each other, some are moving away from each other. And we are living in a place in you know, where two plates are colliding with each other. The Indian plate is pushing against the Eurasian plate. By looking at the size itself, you understand that India is not going to make a lot of progress pushing the Eurasian plate upward. It's not going to be possible because it's almost like a Tata Nano hitting against a truck. Trying to push the truck back, it's not going to happen. So was India always here? Was India always China's neighbor? Let us see where India was then. Some time back, about 180 million years back, India was very close to the South Pole, along with two other cricketing nations, Australia and Africa, South Africa, I mean. And we were all together in one large continent. And this broke up. One large landmass broke up, and India started its movement northeasterly direction. So this is around 60 million years back. India was close to the equator and moving up at about 3 centimeters per year. which is why you can imagine 3 centimeters per year from the equator to where we are. It took millions of years. And roughly about 30 million years back, we were closing in on the Eurasian plate. There was a sea in between India and the Eurasian plate, and the sea soon dried up, and the land went ahead and collided with the Eurasian plate. And like I said before, it couldn't push the Eurasian plate forward, but so it had to do what is called subduction, go under the other plate, one plate going under the other plate, bringing up mountains. So the Himalayas are actually completely a tectonic, as a result of this tectonic collision between the Indian plate and the Eurasian plate. And this is the plate boundary. You can see the black line is what divides the Indian plate and the Eurasian plate. So most of J&K is on the Eurasian plate. Much of Himachal Pradesh is on the Eurasian plate. Much of Uttarakhand is on the Eurasian plate. The plate boundary cuts across Nepal, cuts just below Sikkim, goes into the Assam, Arunachal Pradesh border, comes down, takes a turn, comes down near Mizoram into Andaman Nicobar Islands and into Indonesia. And you see the stars here actually denote large earthquakes, because this is where one plate is pushing against the other plate. And is it a smooth movement? It is not a smooth movement. One plate is not allowing the other plate to move forward. So it is all held up. And when the rocks cannot take the pressure any longer, it breaks. That is what we feel as a major earthquake. And where there has been a big earthquake, the pressure there has reduced. In other places, the pressure is building up. And as they say, it is like a pressure cooker. It has to release energy at some point of time or the other. And we are in for earthquakes. If we have not had an earthquake for a long time, we are likely to have another one soon. So these stars, this is the 2005 Kashmir earthquake, Pir Panjal earthquake, come down the 1905 Kangda earthquake, and there is a big gap here between the Kangda earthquake and the Nepal earthquake of 2015, and then the 1934 Bihar-Nepal earthquake. Along the plate boundary, you come slightly below is the Shillong earthquake, 1897, 1950 Independence Day earthquake here, August 15th, 1950. And then we come down the plate boundary, we have the 1941 Andaman Nicobar Islands earthquake, and then 2004 tsunami generating earthquake, 2004, this one. So that was a 9+ magnitude earthquake. That is the power which is stored in these plate boundaries, 9+ magnitude earthquakes. So, J&K close to the plate boundary, so you are it is like being very close to danger, and let me put it that way. You are right at the plate boundary, and earthquakes are going to affect some part of the state or the other. We need to be prepared. And they say that we are always between two earthquakes. The further away you are from the last one, the closer you are to the next one. So if you have not felt a damaging earthquake for a long time, that's not good news. That's bad news, actually. So if Srinagar has not, 2005 earthquake was far away in Muzaffarabad. It was not a direct hit, but Srinagar has been affected in history. But if you have not been affected by a major earthquake, then you're closer to the next one. We have seen there's a growing earthquake risk in the Himalayas. There have been several earthquakes in the last 200 years. And some of these earthquakes have triggered landslides. That is something we don't remember. We don't really remember that earthquakes can trigger landslides. Because you see, these landslides means the mountains are loose. And when the rains happen, normal landslide is when the rains happen, the friction becomes less and the land slides down. But if the mountains get shaken by the earthquake, that also can trigger the landslide, rock falls. So earthquakes can be, in hilly areas, earthquakes can be accompanied by landslides as well. When we did the assessment of landslides in Aizawl, we understood that within the municipal area of Aizawl, there were 1,115 landslides within the municipal area. That is how landslides can be triggered by earthquakes and rockfalls as well. So we need to understand local hazards. Purnima ma'am mentioned about siting, the importance of siting of health facilities. And I'll just give a small example, not from J&K. Example from Uttarkashi. I'm just looking at one hospital which is already there. This is the Uttarkashi District Hospital of Uttarkashi. Uttarkashi, of course, had an earthquake which killed about 2,000 people. We referred to it in the first slide. And this is an old hospital, an H-shaped hospital building. If you remember Suresh sir's presentation yesterday, you will know that these alphabet shaped buildings are vulnerable to earthquake shaking because there are more number of joints there are between buildings. There are the likelihood of collapses there, damages there can happen. So this is the Uttarkashi earthquake. I see when I look at it this way, I understand that it may not be an earthquake resistant building. That is one thing
golden card banao.
Ashwini Puri sir, can you mute yourself? Ashwini Puri sir, thank you. So this is what I see at first glance when I look at a satellite image of Uttarkashi District Hospital. I zoom out a little bit. I understand it's in the middle of a large settlement. Okay, it's a very crowded settlement. And now I understood that any fire in the community will soon spread to the district hospital as well. So it's vulnerable to local fires as well. I'm zooming out a little bit and I see, oh, the river is not too far away. And it's no small river, it is the Bhagirathi, mighty river Bhagirathi, and there is one bridge across it near where the hospital is. So now you have two problems I see. One is that of a flood issue, and the second is of access. You know, if this building, if the bridge collapses or bridge is made unserviceable by an earthquake or a flood, the hospital is going to be isolated from the rest of the state. And zooming out a little bit further, and I see, oops, I see that the hospital is right at the base of a major landslide. The Varnavath landslide, the very famous landslide, and this hospital is right at the base. So now you understand why it is important to consider all hazards. And when you look at this landslide, it has three legs of the landslide, and two are prominent. The third one is a water channel actually. And if this develops and this slide actually becomes a major slide, it's going to fall into the river. And if it falls into the river and blocks the river here, where is this water going to go? There's going to be a flood as well. So landslide, flood, you know, the scenario after an earthquake can be scary. And this landslide which is sliding onto the river and blocking it, is not going to last forever. It is going to last for 1 or 2 days when the water is going to flood and suddenly the pressure becomes too much and this dam bursts, and then there are going to be floods downstream. Not upstream already had floods. Now we are going to have floods downstream. So scary scenarios, but we have to understand it. We have to understand our risk. The hospital is somewhere there. And if you look at the landslide hazard maps, because in most of the states, the landslide hazard maps we have are 1:50,000 scale. So when you look at this mountain in 1:50,000 scale, it may be red, but this mountain and the next mountain and the next mountain are all red. We don't know exactly where the hazard is. You need better maps when we are, you know, placing something as important as a hospital. We need to have better maps to understand the risk. When you look at the hazard maps which are available with many states, this may not be enough. Aizol did something. I'm talking about Aizol because after they understood the risk, they developed a landslide hazard map, which is of this is tile number 69 of 150 tiles. So municipal area is, the map is in 150 pages. You can imagine that is 1:50, 1:5,000 scale map. That is required. Only then you can site your hospital well. So review of the state hazard maps may not be enough. We need to look at local hazards. That will affect your functionality. And I'm just taking an example. We did an assessment of a hospital, Trashiansi Hospital in Bhutan, is bordering Arunachal Pradesh. And you look at the hospital, looks fine. It is not in a very landslide prone area. We were looking around the hospital. Of course, there are landslides far away, but not within the campus. It is a very hilly area. But when we were walking around, one of our engineers noted that there were a few large rocks here on the side of the hospital, outside the hospital. They noted many large rocks. I mean, it is also important to have the eyes to see. And I was lucky to be with some experts who had these eyes, who had these, expert eyes. That is very, very important. And Aparna mentioned about learning from each other. I was lucky enough to travel on hospital assessments in many places with real experts and learn from them. I mean, these rocks, I would not have given a second look, but when they saw it, they started looking back at history, what happened. They asked the elders of this town what had happened, and even they didn't remember when this had come down. But when we did a detailed analysis study, and we found that, you see, the hospital is here. When you look at, even with Google Earth, we were able to see the real danger that is facing this hospital, because this actually is on the base of an ancient mud flow. Many years back, a mud flow happened. It got covered. These rocks came along with that mud flow right from the top of the hill. Probably 50 years back, 60 years back. The rocks were deposited there, and over the mud, the grass grew, trees grew, and we all forgot about it. So we forgot about the hazard, but there was a debris flow hazard there. And hence there was a suggestion that, we need to study the debris flow before we build anything new in this site. Very, very important. This should have been done before the hospital was constructed. So these, we need to look out for signs of what all can happen. Important to looking out for signs before we actually set up something like a hospital. This is also a rockfall photograph. You look at this. A rock has fallen from the top of the mountain, rolled down, and completely taken. One part of the building has been taken away. It just rolled through it. If you look at where it has gone, it has come from there, and it has just rolled through the buildings, smashing the buildings to nothing, and ended up here. You see this big rock here. The man is standing next to it. I'm just showing it for scale. You see this huge rock coming from there and just taking out the building and completely destroying it. And I was wondering, was there a sign that this could happen? And I was looking at other photographs, and then I saw that there's an old rock here. There was an old rock. The farming was done around it. They have done the farming around it. This rock was already here. So before they set up house there, they should have thought about, where did this come from? Are there more? Is there a rockfall hazard here? Should we keep it right here or somewhere else? That is the question for us to ask when we are especially citing health facilities. Rockfall from Sikkim, a PHC. a PHC in Chungtang which was hit by a rock during the Sikkim earthquake in 2011. And you see this huge rock has come from the top of the, triggered by the earthquake. But for me, the most important rock is not the one here. The important rock is the one here. You see, this was already here. It was covered. It has been here forever. The engineer, when he was siting this PHC, should have seen this and looked around to see where did that come from. Are sisters and brothers of these rocks waiting there for the next earthquake to come down? Should I keep my PHC here? This is a question for us to ask. What are the local hazards? I mean, just showing you an example from Nepal, where a major penstock pipeline was affected by landslide and rockfall. Actually, it broke. I mean, several towns went without water just because of this. That they did not think, they did not look up the hill and think that those rocks can come down and damage my very, very important pipeline. We need to be aware of what all can happen. And especially when we are in hill towns, we have to, I mean, we are more at risk than someone living in the plains. Because these hill towns are earthquake prone, they are landslide prone, there are earthquake induced landslides. Yeah, and we are also rapidly expanding on to more and more vulnerable slopes. The response capacities are limited, the populations are increasing, and we really don't understand the risk. You know, we are thinking nothing is going to happen, as everybody in India feels that, you know, it won't happen to me, it will happen to somebody else. We won't, it won't. So people in cities, mayors will think, I mean, oh, it happened in Shimla, but it will not happen in Bhadarwah. Or it happened in Bhadarwah, it will not happen in Aizawl. It will not happen to us. No, it can. And we need to understand the risk very well. It's very, very important to understand what can happen. This is an example from Japan. I mean, in the beginning of my presentation, I was saying that Japan is well prepared, and they are. But they do make mistakes. They learn from this, but they do make mistakes. This is a hospital in Miyagi. And I have often heard, hospital should be the last building standing. And you look at the community around here, everything else is destroyed. It is the hospital which is the last one standing. It was, but when we take a closer look at that building, we see that this is the hospital which was struck by the 9.3 magnitude earthquake, and then the tsunami passed through it. And we see the sign at the among the debris, the sign outside the hospital which said a tsunami hazard of 2.8 meters. And then we realized that they had thought the tsunami hazard was 2.8 meters, which is why they kept the generators one floor up, about 3 meters. The generators were one floor up. They had actually grossly underestimated the tsunami hazard. The tsunami they received was 12 meters high. 12 meters high. It knocked away their electricity, it took away a few wards, many people died. They were completely isolated. That you know, someone did not really understand the risk completely. It's very, very important before we think that our hospital is prepared, that we should understand. Are we completely understanding the risk, understanding the situation? Another example from Chennai, 2015, Chennai had floods, and many hospitals were affected, but this one hospital right next to the river, Adaya River. This is the river which flooded, Adaya River, and this is the hospital right next to it. I mean, it's hardly 150 meters from the river. And the one thing they did wrong was to keep their generators in the basement. They had a basement. Having a basement right next to a river itself is a bad idea. And keeping your generator, your critical lifeline in the basement, very bad idea. And when the floods hit Chennai, the power supply failed. They were running on their generators. Then soon the river overflowed and flooded their basement. There goes their generator. There goes their power. And unfortunately, 18 people were on ventilator support at that point of time. Couldn't be saved just because of bad design. Generators in the basement. Another hospital we went to assess, right next to the Brahmaputra in Guwahati, 800 meters from the Brahmaputra, all generators and CSSD is also in the basement. Not a good idea. Your hospital is not going to function. We need them to function. So, I will wind up here. Preventing collapse is one thing. Keeping hospitals from collapsing is very, very important. Like I said, it's one element. But there are several other elements which will keep your hospitals functional. Non-structural safety is really important. Site selection, structural mitigation, everything can help you to keep your building safe. But are earthquake resistant buildings enough? What really happens inside a hospital? Let us assume the building is safe and let us see what happens inside a building during an earthquake. This is not from a hospital. I'm showing you a brief video from Nepal during an earthquake in a supermarket, just so that you will get an idea of what actually happens there. This is from a supermarket. You see people are trying to evacuate. They're running over things. The exit is already blocked. You can see many things have fallen down. Things have started falling. They are running. Some of them who are close to the exit were make this lady unfortunately does not make it. She's under something. Then there are people, things are falling. There are people, some of them make it, and some of them, there are things falling all around. Just imagine this is happening in your pharmacy. Just imagine this kind of shaking is happening in your operation theater. What can happen? While a surgery is going on, what can happen? What all is shaking? What all is falling? This is happening in your generator room. This kind of shaking is happening. Can generators move? Your water pumps, can they move? Can they be damaged? Can these water tanks above your buildings move? All of that we will discuss tomorrow. I'm not going to talk more about that. That is one of the sessions tomorrow, and very interesting session on non-structural risk mitigation. So I'm back to where I started yesterday, the ingredients for a functional hospital. So today we talked about understanding the risk, what all can happen, siting of the building, looking at not just earthquakes, fires we looked at yesterday, looking at landslides, looking at floods. Your own floods would have taught you many lessons on what can affect a hospital during, what all can get affected during a flood. So, and many of our services are, coming from outside: electricity, water, medical gases, medical supplies, for the pharmacy. Everything is coming from outside. So here is a need for hospitals to remain prepared, to be on their own during the first 3 days at least. That is when we expect that help will come from outside. So at least for the first 3 days, you have to be, as our Prime Minister says, Atmanirbhar. We need to be self-sufficient. We need to be able to, on our own, able to help the communities, help them in their treatment. So preparedness, hospital preparedness, I will say, I missed talking about the NDMA guidelines. Yeah, NDMA guidelines also talk about functionality. I just wanted to mention that here. The NDMA guidelines clearly say, the vision itself says all hospitals will be structurally and functionally safer from disasters. point number 1. The aim is to mainstream disaster prevention, mitigation, preparedness, and response activities into the health sector, and such that the hospitals are not just prepared, but fully functional immediately after disaster. So, the time for safe hospitals is over. The time for functional hospitals. We need to move towards that, because a prepared hospital, like we started in the beginning with saying Japan and the US, some of the countries which are better prepared, disasters don't affect everyone equally. The prepared ones don't get affected so much. So I will stop here with this little picture and a nice message. You see, both of them have been in the mud for some time. It looks like their legs are in the mud, but the way the mud has affected the little one is not the way it has affected the big one. Disasters affect like this. If we are prepared, we get affected much less. Unprepared, and we don't know whether we'll be able to cope with it or succumb to it. Let us prepare and prevent rather than repair and repent. Thank you so much. I'll be happy to take any questions. Thanks. Bhagwati ma'am, please take it forward.
Thank you very much, Hari sir. That was a very thought-provoking presentation. Many of the images which were depicted have actually made us realize the risk and the vulnerabilities which we are amidst. It has let us hope that this training session, which itself is a measure of preparedness adopted by Jammu and Kashmir SDMA, inspires the health management, the health facilities management people over there, as well as the city administration, to take these measures in practical situations, to prepare hazard maps, and also to make the hospitals and the other critical utilities surrounding the cities, like the water supply, the electrical power distribution systems, all more resilient to any probable disaster in future. With these, I see a few questions which have been raised by Aparna ma'am to Apna Jammu and Kashmir SDMA Amir Ali Saab, and as well as to Hari sir, to you. I would request, ma'am, why don't you ask them directly instead of, please.
Sure. I just thought I'd save time. It's a trivial question. I just wanted to know how many in the hospitals in Jammu and Kashmir actually practice drop, cover, hold regularly. Just wanted to know. And on a more serious note, considering the earthquake zones in context, what kind of assessment criteria do you use for the hospitals, and anything that you would like to share, if you've piloted, because you've mentioned yesterday that, you've done some work, and that sounds very pioneering. So if you would like to share that with other states or NIDM, NDMA, or have you done that already?
My response would be that, regarding the drop, cover, and hold, though, of course, we do advocate that it is required to be done, but I am not really very confident to say that all the hospitals practice it. Of course, in the schools, we are definitely doing it, but probably not in the hospitals. It is something that needs to be done. There are a lot of doctors from the Health and Medical Education Department that have joined us. I think maybe some of them could respond to that. Then regarding the disaster management plans that have been prepared for all the hospitals, particularly of the Kashmir division, they are being practiced, they are being put into action. And yes, we did talk about also our disaster management manual that has been prepared at the division level for the medical education or the health institutions. That is definitely being practiced. Over to you.
And have these been shared with other states, Amir Sahab? I mean, have we made it useful, by sharing this information? Because according to Purnima ji, she was saying some of these criterion, some of these assessment tools, they're not really standardized. But if somebody has already started doing something, would it be useful to share them?
You see, I did share yesterday the link for the manual. the plans are also available on the website. So it was actually pioneered by the then Director General of the Health and Health Services Kashmir, Dr. Salimur Rahman. And now the point is that whether it has been shared with other states or not, well, practically I have not shared it, but it is available on the website for anyone to see. And it would be very nice if NDMA or NIDM would like to coordinate, and we could definitely have a sharing kind of an experience in which I know a lot of work is being done in Kerala. So maybe we could talk to states like Kerala and other states as to what we are doing and learn from them. And probably they would also learn from us.
That would be an amazing opportunity for another set of workshops, actually.
Absolutely.
Amir Sahab. And okay, so the thing about assessment of risk is a question that I still want to know about, apart from the plans. But we'll come back to that later. My question's for Hari. Hari, I don't know if there's a question or just summing up what you said. So I'm just asking. So on an urgent basis, there is a need to identify build or strengthen functional hospitals for each local government area in Jammu and Kashmir and elsewhere, and to see if all linkages exist to these hospitals and that they're functional, that the plans reach all vulnerable populations and are regularly practiced, updated. Is that what you're saying?
I'm not saying it's present. I'm not saying it's present.
No, I'm saying, is that what is needed? Are you saying that's what's needed?
That's what is needed, and we need more and more examples like what Amir Ali was mentioning. We did not. I had opportunity to assess some of the hospitals after the Doda earthquake in Kashmir, and I know what they went through and the changes they have been intending to bring about after that. I know Kerala has, like Amir Ali Saab mentioned. I'm glad you mentioned it, sir, because we did the capacity building for the health department, GHS did, and prepared or helped prepare the disaster management plan for all 14 district hospitals. And we did a 3-day training of trainers at Trivandrum for all these hospitals, along with tabletop exercises. And that is very important. I mean, a hospital drill is not just drop, cover, hold. A hospital drill is to understand how well your plan is functional. A plan. I mean, it's easy to make. With a template we can make a plan, but to actually test it out, that is most important. And I'm sure J&K has done a lot of work in this aspect. But you cannot evacuate patients. Like I said, you cannot evacuate an ICU patient for a mock drill. You cannot. But you can evacuate mock patients to see how well your evacuation is working. Whether you're able to, your team is trained to bring these patients down the stairs, because your lifts are not going to be working. Do you have ramps? Are ramps, one of the main things which come out when we are assessing buildings is the vulnerability of the ramps. In many hospitals, we do the assessment, and among the first buildings to be affected, when the engineers come out with their report, is the ramp. The ramp is the first one to fail, and you see, that is our lifeline for any kind of evacuation. So doing an assessment, very, very important. The WHO has brought out a tool called the Hospital Safety Index. This is something they brought out at Sendai 2015. At Sendai, they had brought it out. But I was, again, lucky enough to have been involved in the preparation of the Hospital Safety Index for WHO as part of the Southeast Asian Regional Office here, there. And Geohazards International did the first field testing of the Hospital Safety Index in Solomon Islands and in Nepal. In Nepal, we did the assessment 6 months before the Nepal earthquake struck. So, many of the findings were actually vetted by the earthquake itself. And so WHO Nepal wanted us to go back to the same hospitals and do the assessment again to vet the tool. So we did that. We found the tool to be deficient. We wanted to improve it. WHO Nepal actually paid to, make the Global Hospital Safety Index for Nepal. So we now have, Nepal has a Global Hospital Safety Index which caters to Nepal conditions. Taking off from that, now currently we are working with UN Habitat and it's a partnership with Myanmar Engineering Services. We are developing the Hospital Safety Index for Myanmar just now. I mean, tomorrow is the last date of that project. We are submitting our final reports tomorrow. So this is there. Hospital Safety Index is available, which looks at the structural stability, which looks at hazards, which looks at non-structural hazards, the utility services, and the preparedness of the hospital. It is a comprehensive tool which really has to be used. But there can be some training programs. Amir Ali sir, we could discuss that in future for a training on usage of the Hospital Safety Index, because understanding what can happen in our hospitals is very, very important. As Aparna, you were mentioning. Thank you.
Yeah,
I think that, sorry. I think that's a wonderful idea that we need to do that, at least a practical session for the hospitals. That is definitely required. Yeah, over to you.
Yeah. So Hari, so just to summarize what you said, there is a WHO index to assess the safety of hospitals, but we don't have that adapted to India yet.
It is a global tool. It can be. It
can be used. It can be used. And is this encouraged to be used by the government yet?
Not yet.
Okay. Okay. No, because I really have to compliment you on your presentation skills. And no presentation worth its worth for disaster management would be useful unless it scares you. And I had goosebumps looking at all those pictures. A lot of them I have seen in the past, I know, but even then, so it really kind of, wakes you up again and looking at all the different zones for hazards in India. And like you said, the landslides, for instance, I'm sure it's not like Hong Kong. Hong Kong's a tiny island. We have 7 million population. We have slope maintenance, which happens 2 times a year, where people climb up and then they put mesh. And I'm not an engineer, but I know that they do it. Surely you can't do it in India. So what you have to do is to locate hospitals in safe areas to start off with.
Hong Kong is small.
Yeah, it's very small. But
have
I do
1:2000
something called maintenance.
Doing 1:2000 scale maps is easy in Hong Kong.
Yes, that's right.
Not
that's
in
right.
India. Not even in our Himalayas. Yeah.
Yes. Yes. So then for existing hospitals, like you have gone and assessed, that exist in areas where there are prone to high disaster risk. What is your suggestion?
If possible, if you're depends on the probability, of something which can happen. Like the Uttarkashi hospital I mentioned, it is right at the foot of a landslide. Do you want to build a new base isolated hospital there? Spending hundreds of crores. Do we want to put it there, or maybe you put it across the river somewhere else, which is less hazard prone? I mean, that is a question for the people who are actually designing these. They should be given that freedom and they should be given that eyes. The problem is, I mean, I'm a civil engineer. I need to be with landslide geologists, geotechnical engineers. Everyone has to come together. You allow an engineer to do, I will build it right at the bottom of a landslide. I only look whether I have flat lines, whether my foundation will go in deep enough. I will look at all of those things. I need the support of other fields as well. And which is, I mean, I talk about our hill towns. None of our hill towns The municipality, they have engineers, but they don't have geologists. They don't have access to geotechnical engineers. And you know, your engineer is handicapped before he starts designing because he doesn't have that support, unfortunately.
But we do have these specialists in India, don't we? I mean, that's what I said at the beginning of my short talk, that there is a pool of professional, well-trained engineers, architects who could be used to
The
make
idea is not to depend on just that pool. The idea is to expand that pool.
Of course.
Which is why we and because you know, Amir Ali sir and Garima and Aparna, all of you, see, we keep meeting each other in workshops and seminars. We are trying to expand the pool, but you know, it is not. We see a few rare new entrants. Bhagavati Iyer comes in, you know, or a Mudassir comes in, but we need much more. And which is why I really like that NIDM, Dr. Garima is spearheading this in her field, that they are partnering with universities. And I am so happy to see that, because when they are the future, we need students interested. We need students to be interested to come into the field of disaster management. This is a race we are struggling to win. We need more and more people to support in this race against the next big hazard which is facing us.
Yeah, as well as mainstreaming disaster risk management into everything else as well at the same time. Because that's when the realization that you need to assess, that you need to plan, that you need to do all this in advance to be able to face disasters better will come.
Yeah.
Very true, ma'am. Thank you very much for your thoughts. A special thanks to Amir Ali sir also for taking time to join again today and staying throughout our session. Thank you very much, sir. We look forward to continue working with Jammu and Kashmir. I would, and again, a special thanks to Hari sir, as always. In his presentation has been inspiring many of us to start thinking about disaster management activities in many of the states, and even inspiring people like us to join this mission of protecting our environment and preventing disasters as much as possible and bringing in preparedness. Garima ma'am, I would like to invite you to deliver our closing remarks for today's session.
Yeah. Thank you so much, ma'am. First of all, I would like to thank all the sorry, I'm having a little yeah. So very vibrant presentations in today's session. I would say that they began with the very important keynote address by Ms. Aparna Kanda, former DRM associate and expert on the subject. She detailed out about the disaster resilience of health facilities through the lens of Sendai framework for disaster risk reduction and the institutionalization of disaster management systems as per the DM Act. So Dr. Purnima from PFI gave a very informative presentation on climate resilient and health infrastructure. She spoke about India's National Adaptation Plan, vulnerability risk mapping for healthcare, which to be done, growing dependence on healthcare service, which is increasing day by day, and we need to make them sustainable. That was one issue which she had raised, and she talked about the building climate resilient health systems through the 6 building blocks. She spoke about leadership, governance, workforce, good services, health financing, health information system. So she spoke a lot about it, and then she also discussed about the climate smart health report, care report. But another important aspect she spoke about was the waste minimization and sustainable healthcare waste management and the reduction of carbon footprints and all. So very nice and very informative presentations. My thanks to her. Dr. Hari, as usual, his very important and repetitive aspect, which he has been, I think, since so many years, he have been focusing on building resilient systems especially the lifeline buildings and the hospital, which is one of his most interest area, and talking about that it is not just important to have a structurally safe as well as a non-structurally as well as functionally safe hospital which can work in the need of so very elaborative and nice presentation on that, and very nice discussions held after the presentations, and we all have learned from it a lot. I believe it is a very good learning experience throughout. I would also like to speak about certain points from my angle. Dr. Purnima explained about the site selection component in the action plan for the climate resilient health system. Of course, when we talk about building resilient, disaster resilient constructions, site selection becomes extremely critical. Though the action plan of climate resilient infrastructure would only talk about the disasters which could be due to changing climate phenomena, could be floods, excessive rains, or landslides or so. But I agree with Hari sir that it is very important to understand the geotectonics and structures and processes of the earth crust when we plan for resilient health structures. So he gave so many examples, especially in context of Jammu and Kashmir, that how the vulnerability increases when it is in an earthquake zone, when you speak about the health facilities in the earthquake zone. And I also had done a small study on this aspect. So I would like to take reference from that study. My study actually spoke about the public services, how they are located structurally on geotectonics, and then we have done a detailed study on structural and functional aspects of those public services. So I try to overlay the locations of public services, including district office, hospitals, public health centers, schools, power supply, and so on a geotectonic map of the towns of Himachal Pradesh. So we had selected 5 towns, and I tried to overlay the locations on the towns along with the geotectonic maps, and we found that many facilities, maybe health facilities or schools and all, are running through the fault line, especially the main boundary thrust line, which is the active zone for earthquake, and the location of hospitals, few hospitals or schools or some certain important facilities which are built either on the fault lines or near the fault lines. So the resilience cannot be achieved unless we include risk assessment as an important component of planning of health infrastructure. It is extremely important that we study the resilience part from the point of view of all the disasters, either it is climate or it is geotectonical related aspects, and also all aspects should be covered and should be a multi-hazard risk assessment should be done, which is extremely important, as it is not possible to have a functional hospital after an earthquake if the building is built just above the fault line. So these detailed out studies are actually required. We have to see how the hospital will be surviving in structurally unsafe building in such situations, and how can we, especially when an earthquake is of a very high intensity. So these questions have, I think Hari sir has very nicely also answered that this is a multi-pronged approach, and we need multi-stakeholder to conduct such a kind of studies, and the collaborative effort is extremely important in that. So, so I will not talk about the non-structural and functional aspects now because it is tomorrow's topic, and but I would say these are the most neglected ones in most of the cases. And these are something which we can strengthen. At least we cannot change the existing buildings, and we may not be able to retrofit them immediately, but non-structural aspects and functional aspects are something which can be done, and we should do them in priority, and which is going to really help us to build resilience of health infrastructure. With these words, I would like to thank all the panelists for being here and helping us in conducting such a elaborative discussion and exchanging knowledge on various subjects. My special thanks to Aparna for being here throughout for 2-3 hours and assisting us in conducting moderating the discussions as well. So nice of you, ma'am. Thank you so much. I think all the questions are answered. Over to Bhagwati ma'am, to you. You may now close the session.
Thank you very much, Garimaji. It'll just take a moment to share my screen.
Okay.
This certificate is being issued to Dr. Purnima ma'am for being our esteemed resource person for today's session from NIDM. The other participants will be receiving their certificates from NIDM as and when they register and complete their attendance for the 3 days. So with this note, with all the learnings we take home, I thank everyone once again for your time and for all the patient listening throughout. We have exceeded the time by almost 20 minutes, but still being with us from the beginning. We have still around 50 participants in our list. So thank you very much. We hope to see you again tomorrow, same time at 2 o'clock. Till then, stay safe, stay blessed.
Thank you. Thank you so much. Thanks.
Thank you so much. Thank you again. And I hope something really wonderful and useful comes out of this.
Definitely. Thank you so much.
Thanks, Aparna.
Thank you, everyone.
Thank you.
Thanks for joining us.
Thanks, Garima. Thanks, Bhagavat.
It's so nice to see you.